Vanakkam all of you. Speaker chairperson, seniors and dear delegates. I'm going to present on DNA fragmentation in routine semen analysis. So when Dr. Nadesh discussed this topic with me, all I could make out was that, it's a very difficult topic to understand. So I discussed with him and finally we could reach a conclusion that, what we are going to talk about. So without wasting much time, we would like to start with it. So just a brief introduction on male infertility. It's a branch of medicine which deals with deficiencies in semen, genetic and congenital conditions, anatomic defects, endocrine disturbances, immunological and functional abnormalities, and sexual conditions incompatible with intercourse and chronic illnesses. It's a social stigma in our setup, or for any setup in the world. It's a very prevalent condition. If you look at the infertile couples, almost 50% is contributed by the males. And it's responsible for 10% of all the couples and around 50% of the infertile cases. So it's a huge chunk of population. So if we look at the evaluation of male infertility, a lot of people rely on semen analysis. Do we have a pointer? Pointer. And the semen analysis has got huge lab-to-lab, subject-to-subject variations. So people thought of developing some other parameter which can look deep into the sperm and which is not that variable. And then came the concept of DNA fragmentation. So what exactly is DNA fragmentation? Now during the process of spermiogenesis, the sperm has to metamorphose from a round cell into a thin tubular cell. So very tight, in a small vessel, huge amount of DNA is getting packed. So during this packaging, the histones are replaced by protamines. So 85% is protamine bound and 15% is histone bound. And if there is any difference in this arrangement, then starts the process of DNA fragmentation. Because the histones are less tightly compacted and protamines are tightly compacted. So if you have to package a lot of material into a small vessel, the packaging has to be tight. And this DNA strands, when they are not packed well, they are susceptible to damage. The process is known as sperm DNA fragmentation. And it's seen in increase in sperm of infertile men. So now we have talked about DNA fragmentation. It's of two types, single strand and double strand. Single strand is due to unrepaired DNA nicks. Small nicks will lead to single strand damage, whereas because of action of capsases, endonucleases and ROS, double strand DNA damage will result. A double strand, even if it's a few double stranded DNA damage, it can lead to gross alterations in the chromosomal structure and embryonic arrest can happen. Whereas a single strand DNA can be repaired by the oocyte and it has a better prognosis. A double strand DNA damage is much more deleterious. So what are the causes of DNA damage? Why are we interested in studying about this? So one is a defective chromatin maturation, as I discussed in my previous slides also. Abortive apoptosis is another process which we will go on to explain. And ROS-induced DNA damage. So when you talk about defective chromatin maturation, it is the failure of oocyte or the sperm to repair the existing DNA nicks or the introduced DNA nicks, which leads to persistent DNA breaks in viable ejaculated spermatozoa and triggers apoptosis. Moreover, this defective chromatin maturation makes the sperm DNA more susceptible to ROS-induced damage during its transit through the male genital tract. And these can lead to decreased fertilization rates, decreased embryo quality, elevated developmental arrest, and impaired pregnancy rates. So the most critical thing which we see in this is when many times we see a block at the 2-gene stage or the absence of sperm DNA decondensation, in which the fertilization may not even happen. The process of abortive apoptosis. Generally, any defective sperm will be apoptosed and will not be able to enter the ejaculate. But if it escapes apoptosis, the process is known as abortive apoptosis. and then the normal looking sperm, which may be aneuploid or with DNA damage, may enter the ejaculate, and they may present as a high DNA damage. So either it can be a normal sperm parameter or it can be abnormal sperm parameter. If you look at the ROS-induced damage, practically there are few things which are related to the ROS damage. I think Dr. Vidhu will be covering the ROS in much detail. So we have lifestyle factors like smoking, drugs, alcohol, then you have got environmental factors like pollution, then you've got male accessory glands infection, in which leukocyte will generate 1,000 times more ROS than spermatozoa. Even you can introduce iatrogenic damage by the process such as centrifugation, in which the duration of centrifugation is much more critical compared to the speed of centrifugation. So if you have to centrifuge at a high speed for a lesser duration. So all these things together, along with varicocele, systemic pathologies such as diabetes, cancer, chemotherapy, cryopreservation of semen, all these can lead to ROS-induced sperm DNA damage, which, if it is not repaired by the oocyte, can affect in the resulting embryo and can lead to implantation failures also. So another thing, the oxidative stress, which is at times it is not sufficient to induce cell death. It may not kill the sperm, but it may affect the process known as motility, sperm zona recognition. That is, it is impairing the functional aspects. It is affecting the motility, sperm zona recognition, acrosomal exocytosis, and sperm oocyte fusion. So the functional impairment is seen, but the sperm may look normal. So it is like an army which is, looking fit and fine, but they have no guns to fight. So they are practically functionally paralyzed. Looking at the incidence is much higher in men with abnormal sperm parameters compared to men with normal sperm parameters. It is seen even in fertile donors, you will see. It is seen in patients with abnormal semen parameters as well as normal semen parameters. But the frequency of or the incidence goes on changing. So it is almost 3 times in normal patients compared to patients with normal sperm parameters, whereas in fertile donors, obviously we take donors with healthy DNA also. We select them on the basis of a DNA test also. If you look at the consequences of a high DNA fragmentation and you take it in regard to spontaneous pregnancy, so it was seen by Evanson et al. That there are no pregnancies if the sperm DNA damage is more than 30%. And time to pregnancy is inversely related to the DFI levels. So these things have been proven time and again by various studies. So unexplained idiopathic infertility, if it is resulting in a marriage, then you must think of evaluating the sperm DNA damage. If you look at its relation with ART or assisted reproduction techniques, this was a landmark study carried by Bangam in which she took almost 1,000 patients, and she found that in case the DNA fragmentation is more than 30%, the IUI process is not going to work. The implantation rate was negligible if you are doing an IUI. So in such cases, if the DNA is more than 30%, as I said, the pregnancy as well as the biochemical pregnancy, clinical pregnancy rate will be negligible. So in such cases, ICSI is the order of the day. So you should preferably go for ICSI in which the OR is much higher. If you look at the pregnancy loss, in case the DNA damage exceeds 60%, then the pregnancy loss is much, the OR is almost 2.4, the odds ratio. So the pregnancy, if it all, it will result will lead to miscarriage. If you look at the live birth rates, again, the incidence of live birth is much higher in cases in which the DNA fragmentation was low. So all these studies have gone on to prove that DNA fragmentation is an essential component. Though we'll come to the guidelines later, the guidelines think differently still. Recurrent pregnancy loss, again, this was a meta-analysis published in the Embryology Journal, and they say that in cases of recurrent pregnancy loss, the association with high DNA damages is much more than compared to low DNA damage, and all the studies and different techniques such as SCS, eternal, COMET, everything has proven that high DNA damage is deleterious to the ongoing pregnancy. So this is what is known as a late paternal effect, whereby the implantation and the persistence of pregnancy is dependent a lot on sperm DNA integrity. Now this was the ART, and DFI is associated with a lot of other conditions such as varicocele, and DNA fragmentation has been reported to decrease by more than 5% in case of varicocele patients. So varicocelectomy will bring down the DFI levels by almost 5%, and which will enable a natural conception also in case the patient is trying to conceive. Male genital tract infection, as I said, the sperm, any semen leukocytes will generate high levels of ROS, and so thereby leading to increased DNA damage. Advancing age, increased paternal age, smoking, obesity, radiation, environmental toxins, everything is contributing to increased ROS and increased DNA damage. Whereas a shortened ejaculatory abstinence time, many times we ask the patient to bring the sample after 1 hour of ejaculation. We ask them for frequent ejaculation during the whole, while the wife stimulation is going on. You ask the husband to frequently ejaculate. So these things do bring down the DNA fragmentation levels. And if case nothing works, then the final answer is testicular sperm. On the belief, there is another presentation on this, testicular versus ejaculate. So we'll cover the rationale in that presentation. Now looking at the tests which are there to evaluate the DNA fragmentation. So now we have got 4 tests: sperm chromatin dispersion, the halo test, tunnel, comet, SCSA. So all of them have got their own strengths as well as weaknesses. But the chief weakness is that no test has an established cutoff value, that above this things will be deleterious and below this things will be okay. Yes, people have proposed their levels. There has been a meta-analysis by Santi et al., but there has been no university or Cochrane accepted levels for DNA damage. Again, the tests are very expensive. They cost almost 6,000 to 9,000 in India and almost $150 to $300 in a country like USA. Again, combining the cost with the specificity is quite low. Even the highest specificity is offered by tunnel, which is close to 60% only. Practically, if you look at any other diagnostic test, you will find that this is a very low specificity. So what are the reasons of low specificity? Number one, fertility is a couple concept. So the wife also has to be normal with all the tests worked up, and she should be normal to be able to conceive. The assays, the tunnel, SCSA, all have their own shortcomings and they have to be considered. Then comes the oocyte's ability to repair. If there is a minor DNA damage, oocyte will be able to repair. So the test loses its significance if your values come to 33%, and it's a case of young wife, she is able to repair the sperm DNA damage. Then the test loses its significance. The patient comes to you, you made me spend 7,000 rupees on a test which has got no significance. Again, the damage may not be in the coding region or the protein transcoding region. Another thing is that some of the tests measure DNA damage in individual sperm cells, such as the comet test, whereas some will study 100 tests and will tell you that 30 are effective and 70 are okay. And you might be, there's a likelihood of selecting a good sperm from those 70, and that will not be damaged, and that might produce a baby. Another thing is the tests are deficient in their analysis because there's a cryptic population of sperm. It's known as the cryptic phenomena, in which many of the sperms which are predisposed to a DNA fragmentation, they're about to fragment, but the test doesn't pick them up. Even the most specific tests such as tunnel will not pick them up. So they are about to be fragmented, and as soon as they are exposed to any kind of hydrogenic or any kind of oxidative stress, they will fragment. But the test will not pick it up. So that's a cryptic population, and the test results will always be erroneous. So tests have got their own shortcomings. There have been reports of viable pregnancy with elevated fragmentation levels, and decrease in fragmentation rates with the latest techniques such as MAX, PIXI, and other microfluidics have not led to any improvements in the ART pregnancy rates. So what are the guidelines for SDF testing? So this was the first guideline which came in the Society of Translational Medicine. They picked up on 4 things: varicocele, unexplained infertility or IUI and RPM, and IVF and ICSI failure, And the last was borderline semen parameters as a risk factor. So all the evidence was grade C if you look carefully. Grade C is the evidence where there is no randomized control trial or any concrete trial supporting the evidence. Then surfaced these recommendations by Agarwal and STVs in 2018 and 19. I'll take just 3 more minutes. Again, the indications remain more or less the same, but the STVs also laid down the recommendations for how to test the patient, because different labs are doing it in different ways. So he laid down the conditions that this is how you should test. There should be the abstinence, there should be the time of processing and all. Everything was laid down, and they also agreed on a cutoff of 20% for all the tests being offered. So the cutoff which was discussed as 30%, with this meta-analysis it came to 20%. So again, there is a lot of confusion in this test, and the specificity is also low. Agarwal recommended the use of antioxidants and recurrent ejaculation, lifestyle modification, whereas STVs didn't recommend any of these, and he said that it's a grade C evidence for all the recommended treatment methods. The Journal of Urology in 2021, I'll just quickly do it. They said that there are no prospective studies that directly evaluate the impact of DNA fragmentation testing on the clinical management of infertile couples. And this assay should not be routinely performed in the initial evaluation of the infertile male. I know Dr. Natesh differs with me on this, but that's the consensus by various guidelines that it should not be routinely recommended for infertile patients. The European Journal Association of Urology, these guidelines, they also had a similar opinion. They said that the diagnostic utility of SDF in male infertility should be performed only in the cases of people going for ART, that is for a risk stratification for patients undergoing ART, as well as in the case when patients of varicocele to guide the treatment and to evaluate the benefits of the treatment. So there is a lack of definitive cutoff. Utility of testing has very low evidence, low quality evidence is there, and studies have failed to find a significant association between high SDF levels, idiopathic infertility, RPL, whatever indications are there are supported by type C kind of evidence only. So there are a lot of gaps in knowledge. I think we have gone through the gaps in knowledge during this discussion. So just to summarize, the DNA fragmentation test should be done in varicocele, unexplained infertility, RPL, IUI, the certification of ART techniques, fertility counseling, as well as in sperm freezing. And if case the DNA fragmentation is found to be high, the lifestyle changes and antioxidants, etc. should be introduced. If it works, fine. If it doesn't work, then the only option you have is a testicular sperm or a testi-ICSI as they call it. And even FSH level has shown encouraging results. But yes, quitting smoking, controlling your weight, a good lifestyle in general, antioxidants, treatment of underlying conditions such as infection and varicocele, as well as offering a testicular ICSI in the last, that remains the algorithm for treatment. So I would like to conclude that still SDF is I think it's in an infancy phase, and a lot needs to be established before recommending this test with confidence to the patient, because it might bring out things, it might be a good counseling tool, but yes, there is very low grade evidence to support its utility. Thank you so much.